Hi, my name is Scott Ensley, and I'm an editor on NPR Science Desk. I'm also today's moderator of our panel about COVID-19 vaccines. Joining me today are Sarah Fortune, John Laporte Given Professor of Immunology and Infectious Diseases at the Harvard Chan School, Barry Bloom, the Joan and Jack Jacobson Research Professor of Public Health and former Dean of the Harvard Chan School, Mark Lipsitch, Professor of Epidemiology and Director of the Center for Communicable Disease Dynamics at the Harvard Chan School, and Rochelle Walensky, Professor of Medicine at Harvard Medical School and Chief of Infectious Diseases at Massachusetts General Hospital. The event today is part of the Dr. Lawrence H. and Roberta Cohn Forum series. The forum thanks the Cohn family who are watching online today. We are also streaming live on the website of the forum and on Facebook and YouTube. We welcome your questions, and you can email them to us at theforum@hsph.harvard.edu. We've only got an hour and a lot to cover, so let's get started. I think many in our audience would know that Pfizer and Moderna have both announced vaccines that appear to be more than 90% effective at preventing COVID-19. And there are dozens more vaccine candidates making their way through clinical trials around the world right now. We can almost see the light at the end of the tunnel, but we are not out of the tunnel yet. The coronavirus is spiking around the world. Here in the US, we are now recording more than 150,000 new cases every day, more than double the previous peak in July. And there are many unanswered questions about these new vaccines. How might they be distributed? How do we make sure that access to them is fair? Will people even be willing to take them, given hesitancy about vaccines generally and about these specifically? Today, we'll look at the latest vaccine developments, and we'll take on some of these questions. But before we begin, let's watch a short news clip about the announcement of Moderna's vaccine results, as well as Pfizer's. This clip is shown courtesy of Reuters. If you'd please roll the clip.
Fresh hopes for an effective vaccine on Monday. Moderna says its experimental shot is 94.5% effective in preventing COVID-19. That's based on interim data from a late-stage clinical trial. It makes it the second US company to report results that far exceed expectations. Together with the Pfizer vaccine and pending more safety data and regulatory review, the US could have 2 vaccines authorized for emergency use by December. A key advantage of Moderna's vaccine is that it does not need ultra-cold storage like Pfizer's, making it easier to distribute. Production of the Moderna shots will partially be carried out by Swiss biotechnology firm Lonza at plants in the US and Switzerland. The news sent Moderna shares up around 17%. Also on Monday, Russia said it expects to produce primarily freeze-dried Sputnik V coronavirus vaccine doses by the spring. That would eliminate the need for transport at ultra-low temperatures. Russia has an ambitious plan to inoculate its population, but vaccine developers globally are scrambling to work out how to ship and store their vials, some of which must be kept in specialized freezers at extremely low temperatures. The logistical challenge was brought into sharp focus after promising interim trial data for the vaccine developed by BioNTech and Pfizer. It's been considered a major breakthrough in the race to curb the pandemic, but it needs to be shipped and stored at -70 degrees Celsius, equivalent to an Antarctic winter. That poses a challenge for even the most sophisticated hospitals. For the moment, it also puts it out of reach for many poorer countries.
Thank you for that clip. I'd like to turn to Sarah Fortune and ask, what do we know about these vaccines from Pfizer and Moderna? And could you help us understand where they fit in among the other vaccines that are being developed by other companies and governments?
Sure thing. So this is very optimistic news about the Pfizer and Moderna vaccines. And it is optimistic both because the efficacy numbers far exceeded expectations. So the degree of protection that it provided was really sort of a home run. And I think we would have been happy with a much even lower number. And then the other thing that is very interesting about those vaccines is they represent a really new way of delivering vaccines to people, something called mRNA technology, which is a more nimble way of developing vaccines. And so this really represents the success of new vaccine platforms. But other vaccines are coming really quickly behind. And importantly, there are two vaccines that represent maybe a more standard way of delivering vaccines, using sort of repurposing viruses actually to deliver vaccine antigens. And so those are vaccines being developed by Johnson & Johnson and AstraZeneca, both of which are in large-scale clinical trials right now, which I think we should expect to have efficacy data for in short order. And I think as we move forward, the critical things to think about will be these logistic challenges with different vaccine candidates that was well described in the clip. The virally vectored vaccines might be simpler to deliver and require 1 versus 2 doses, but it will also remain to be seen what their efficacy numbers are relative to the mRNA vaccines and their safety profiles. And so there's a lot to learn, and as those numbers come in, we really will face significant logistical and kind of ethical questions about how and where we're going to use these different vaccine candidates.
Thanks very much. Barry, these vaccines have been developed in record time. Could you help us understand how the companies and researchers have pulled this off? And is this something to applaud or be concerned about? Were there corners cut somehow in the process?
Thanks so much, Scott. What I would like to argue is that the race for COVID vaccines has been a lot longer than you have probably been aware of. Let me start with 9/11, 2001, with the attack on the United States, a terrorist attack followed by an anthrax attack. And that led the National Academy of Sciences to convene a set of committees to look at the vulnerability of the US to pandemics and terrorism. And I was privileged to be part of that report. And it concluded we were enormously vulnerable and we had to do a lot of different things if we wanted to protect the country. That was followed in 2003 by SARS. And we were very lucky that by good public health interventions, SARS didn't spread and become a global pandemic, but it could have. And that led in 2006 to the creation of the National Pandemic Influenza Plan. Assuming that we will sooner or later see epidemics and pandemics, how do you get ahead of it? It's a wonderful plan. It could be used for anything, influenza or any other, but it disappeared in a drawer somewhere in Washington when COVID hit. And many of those plans, including the people in the White House and the National Security Council, disappeared. So we were faced with COVID, but where did these new speedy technical developments come from? And I want to mention two things the government does do right, and those are two committees not commonly recognized. One is called DARPA. It's the agency from which its predecessor made the internet, and it invests in very long-term science and technology, stuff that will pay off in 20 years. And they got into looking at biomedical interventions that would take a long time to develop. But to development, you needed another agency called BARDA, the Biomedical Advanced Research Authority, that could invest in those sciences and invest and link them to companies to get products from the new ideas. And BARDA has been behind much of the development of investing in Moderna and in many of the other producers of these new vaccines. And what they sought, as Sarah said, is new technologies The shortest time a vaccine has ever been commercially produced was 4 years. The longest is 27 years. BARDA set a goal of getting a vaccine from the day you know the DNA sequence of a pathogen to be 60 days. The Moderna vaccine was in people's arms in 66 days following the posting of the vaccine. And that's a reflection of tremendous foresight by these technical agencies working to utilize science, bring the companies together, and engineer not one vaccine for any new pathogen that comes along, starting from scratch, but platforms in which recombinant DNA could switch antigens and genes around to be able to plug in any new pathogen, potential antigens, into a platform that has already been tested, not for efficacy, but had been tested for Middle East respiratory syndrome, influenza, and HIV in the beginning. So we had a background on these vaccines. The companies were pretty confident they would work, but it will take the trials that Sarah mentioned to establish how safe and effective for COVID they really are.
That's great. Thank you very much for that context, Barry. I think the background there and the history that led to this moment is not widely known. So really appreciate that. Mark, maybe we could turn to you now. Despite these big and optimistic sounding announcements, it's still going to be a while before the general population is going to be able to get COVID immunization. I have a two-part question here. One is, what is it that we're asking the vaccine to do? What is it that we can expect as far as its effects? And then between now and when the shot is widely available, how do you see the sort of public health landscape playing out?
Yes, thank you, Scott. So I think the next few months will be, if all continues to go well, we'll see million people. And so that means that the initial efforts will be to use the vaccine, the limited supplies of vaccine, while making more, but to use what we have as well as we possibly can. And in vaccines, in the use of vaccines, there are sort of two general ways that we use them, and most vaccines get used in both ways. One is that we vaccinate the people we most want to prevent the disease in. And the other is that we vaccinate people who are important to transmission so that we can slow down the spread of the infection and protect those who would get the most severe disease, even if we don't directly vaccinate them. And of course, in the long run, the goal is to do both. But in the short run, the groups that have considered the pros and cons based on experience with other viruses, based on mathematical models that our group and others have been working on, and based on considerations of ethics as well, those groups have suggested that the early doses should go to healthcare workers, especially those with great exposure to COVID, and to those elderly and people with high numbers of comorbidities, especially those living in group settings like nursing homes, who are at greatest risk of getting very sick or dying if they get infected. So it's a very much a direct protection strategy combined with a view that the healthcare system needs to be protected and the work of the healthcare workers needs to be rewarded. As we get better sense of the values of these vaccines and what they exactly do, how well they protect against infection, which we won't know immediately. We know that they protect against disease, but we don't know whether they slow down transmission. As we learn more about that, if we do, then we can start to transition to a more indirect protection strategy while maintaining protection, vaccination of those at highest risk.
pardon me. Before I turn to Rochelle, I had a question for you, Mark, about what do we know about how these vaccines may work in different subgroups? The elderly and children spring to mind.
Yeah, so in the initial trials, children were excluded. I know at least Pfizer, and I believe maybe some of the other companies are beginning to include older children in their trials. But right now we know nothing directly about how well they work in children. And we know for various vaccines how well they make an immune response in older adults, which in some cases is just as good as in younger adults, and in some cases is not quite as good. But what we won't be sure about at the beginning is exactly how well they protect those older adults. And the reason for that is the simple matter of numbers, that when we stop the trial at the point where we know with statistical precision how well the vaccine works in everybody, that means by definition that if you want to know a more detailed question, say about the elderly, then you don't have enough data yet to say that with the same precision, because you need a given amount of cases before you can tell how well the vaccine works. And so far, what we have is enough cases to tell overall. There are going to be data because some of the cases are in the elderly and in other subgroups. So we will have some data, but it will be more uncertain. And that's one of the points that factors into the decisions about whom to vaccinate when.
Thanks very much for clarifying that. Rochelle, maybe we could turn to you now. It's wonderful to have some vaccines available, but they're only as good as they can be when people get them in their arms. So how indeed will we go about, assuming that the vaccines are cleared by the FDA for emergency use, how will we go about deciding who gets them and making sure that they get out to people in a timely way?
Yeah, thank you, Scott. There's a famous saying among vaccinologists that vaccines don't prevent people, but vaccinations do. And I think that that's exactly what we really need to harp on here. If you look at the Operation Warp Speed website, you can see the amount of money that has been spent in some of these spaces. So billions have been spent in development of a vaccine, and we've heard a lot about it, investments in companies to be able to do this, to get us to where we are in 11 months. But really only about millions have been spent on trying to think about how we're going to distribute this vaccine across the country, how we're going to message it, how we're going to gain public trust to be able to deliver it. We and others have spent some time doing mathematical modeling that has demonstrated that you'd actually prefer, if you had a choice, a less effective vaccine than the one we had, if you could effectively scale it up really quickly and get the coverage and trust really well. Obviously, we have two great vaccines, so that's terrific. But that really does mean that the equally important work needs to be done to distribute and get coverage. And I think of it sort of as sequential processes. You need to have an effective vaccine, and that's going to be multiplied by how fast it is given to people, and then multiplied again by whether they're willing to take it. So all of them sort of decrement if people don't get it in their arms. There are substantial logistical challenges with this. The -70 freezing was one that was raised for the Pfizer vaccine, and that is certainly among the challenges. We need to keep the cold chain for those. Moderna's is a little bit easier. It's only -20. Those are more standard fridges, or front fridges and freezers. So that makes it possible. And certainly academic centers, universities, and pharmacies are working together to collaborate towards their -70 distribution. But what that definitely means is that people who have access to -70s are probably going to get more like the Pfizer, and those that have less access are probably going to be in more rural areas and other places that are harder to reach. On top of that, it was mentioned it's a dual vaccination strategy. So you need two vaccines, which means people need to come first, and then they have to want it enough again to come the second time. When you look at influenza vaccine coverage in the United States, it's about 50% in any given season, 50 to 60%. And that is with mass vaccination campaigns and only a single dose. So I think we really need to understand, you know, how we're going to get people to want the second dose, even if they've gotten the first. And then I think we really have a substantial effort in the record keeping of this. So not everyone is affiliated with a medical record. They don't necessarily have Epic in every place. And so I really do think people are going to, and we're going to need to document lots that were given, dates that were given, when people are coming back. About a quarter of Americans don't have a primary care doc. So they for sure don't have, they likely don't have a medical record. Where is it they're going to be their home to get these distributed? There are some people who believe that you can actually get a second dose of a different vaccine. That has not obviously been studied, but that's going to be important to understand. And I don't think anybody's necessarily interested in having that be the rollout plan. So I think there's going to be a substantial amount of record keeping that we're going to have here as well. As Mark noted, the National Academy of Science, Engineering, and Medicine has helped us figure out who's going to get the first phase of this, healthcare workers, vulnerable populations. But even as you think about that, there are 20 million healthcare workers in the United States and another 60 million essential workers. I think the thing that helps us out in these early phases is that most people in our healthcare working system have a medical record in their own healthcare system. And so we can work out some of the kinks as we're vaccinating that first group. And then also to emphasize, certainly we want to vaccinate the healthcare workers that are doing frontline work. But I also want to, the nurses and doctors, but the vaccination strategy here also has to include environmental and food services and other people who actually come potentially from higher risk communities.
Thanks very much for laying out the daunting challenges here in distributing the vaccine. I think as you point out, the 2-dose regimen, at least for these first vaccines, really adds to the challenge. And I know that in the ACIP meeting a month or so ago, the CDC talked about issuing vaccine cards to people, which was something that they might carry around, but seemed like a rather old-fashioned solution to this problem. So let's see how it develops. I'd like to thank the panel for these insights, and we're now going to move into the next phase of our panel, where we're going to dig in deeper, talk about some of these challenges, and then take some questions from the audience. Before we do that, let me remind you that this is the forum at the Harvard T.H. Chan School of Public Health, presented jointly today by NPR. Viewers can email questions to the forum, all smashed together, at hsph.harvard.edu. Before we begin the next part of our discussion, let's watch a short video clip about one of the important challenges to a broad vaccination effort, and that is that some people just may not want to take a vaccine once it is available. So if you could roll that clip now, that would be great.
News of Pfizer's coronavirus vaccine success is being cheered as a breakthrough in the pandemic battle. But in addition to the many logistical battles it may still face, a study released in the UK on Tuesday warns of another human obstacle: misinformation and public mistrust of a vaccine. As many as 36% of people in Britain say they are either uncertain or very unlikely to agree to be vaccinated against the virus, according to scientists behind the research. The feeling amongst the medical community, however, is that an 80% uptake of a COVID-19 vaccine may be needed to protect communities from infection spreading. Opinion polls carried out before and during the pandemic have also found that confidence in the effectiveness and safety of vaccine varies dramatically across different countries and populations. This was mainly due to political polarisation and online misinformation being the likely reasons to affect the rates of uptake. The British Academy and the Royal Society carried out the research and said an open dialogue is critical to building public support for vaccination, and also called for a frank conversation to manage public expectation about when life can return to normal.
Okay, thank you very much for that clip, also from Reuters. I'd like to begin the conversation in asking about this vaccine hesitancy issue. This is not a new issue, but it seems likely that these very new kinds of vaccines for a very new disease could heighten some of the hesitancy issues. So is there a way that we might be able to talk with people about the vaccines, the way that they were made, and also what the benefits and risks might be? How do we combat misinformation and improve sort of education and communication around these things? And I'd maybe like to ask Barry to start with that, and then Mark, feel free to weigh in as needed.
So one of the very curious things about vaccines that are different than drugs, which drugs are given to people who are basically sick. Vaccines are given to healthy people, and the principle of medicine from the ancient Greeks is to do no harm. So safety is really the highest consideration for any vaccines that go into normal people. And what I would say is, while the speed of development of the technology has been fantastic, the clinical trials have been absolutely as rigorous and standard, based on the statistics of how many people do you have to show are protected by a vaccine to be 95% sure that they are effective. And that has been done in the first two cases, and I'm confident will be done in all of the rest. So they've all been through testing for immediate safety after the injections. They've been tested to see that they make an immune response that should be or could be protective. And then in the phase 3 trials, we know that there were very few adverse effects, none of them really serious, and that we got 90 to 95% protection. Let me just put it from the other perspective. Something unusual has happened that's never happened before. Because of the crisis, companies started to manufacture these vaccines at millions of doses before they knew the vaccines were even effective or safe. That's a huge gamble, and I would have to say it would be very unlikely for any of these companies to gamble $1 billion with having great confidence from the prior construction in these platforms of MERS, of Zika, of other vaccines and the experience they've had, that this was going to turn out to be pretty safe and pretty good. But it took the phase 3 trials to get the data for the first two that really demonstrate that they're safe. The next step that I think people have to appreciate is it's not all over when the government issues an emergency use to say, because of the crisis and the emergency, and because of the data for a couple of vaccines look to be safe and effective, we can get them started in people that Mark indicated at high risk. But they have to be followed for some long period of time to be sure that there are not small, rare adverse effects that may be associated with the vaccine. And that's tough when you're looking at tens of thousands of people who are going to have heart attacks and strokes and get run over by cars and commit suicide. And then you have to show that that is or is not related to the vaccine. So what's called post-marketing surveillance, phase 4, is a major way of establishing that they continue to be safe. And then we can discuss, and perhaps Rochelle will come to the question of how do we inform what we know about safety to the people who have to have hesitancy before taking the vaccine.
Mark, is there anything you'd like to add?
Yeah, I agree with everything Barry said, especially, well, all of it. I would add a couple things. One is, I think that it's going to be important to get the word out that that there are mild and even rather unpleasant adverse reactions that happen at the time of injections. Almost 10% of people in the Pfizer group got fatigue following vaccination. And there was an article in Science magazine a couple of days ago in the news section pointing out that these are not long-term risky. They're not signs that you've been made sick by the vaccine, but they are signs that you've been made to feel bad for a couple of days. So I think we need to get ahead of that and make sure that people realize that that there is a risk of that, and that's part of the experience for some people, so that doesn't become a surprise or some kind of an issue. I think the second thing I would say is that, as Barry said, scientists work on data, and the data are for 2 months so far, and we're going to continue to monitor the safety, and I hope also the effectiveness, although that's going to be much more challenging over time. And the last thing I would say is that, you know, there have been these surveys of people, and I think they are red flags. Those surveys say, at the moment, people are quite skeptical of vaccines. But I think as we work to try to give real information that responds to those concerns, we should also remember that if you ask someone a hypothetical question about, in the future, if there's a vaccine, what will you do? That's a moment in time. And when people see their friends getting vaccinated and the benefits of the vaccine, and they also see the people that they are safe among their friends, I do think there's an opportunity to see changes in people's attitudes, and we need to amplify those messages, and also not stereotype people. One of the things Barry and I have learned on a committee that we sit on for the Massachusetts state vaccine allocation is that there have been reports that people of color as a group are more skeptical of vaccines, but some texture to that has come from at least one mayor that that's a member of that committee, who's pointed out that among certain communities of color, there's actually very strong desire for vaccines, immigrant communities in this particular example, and that we should, while we're being sensitive to cultural differences, we should also really be sensitive to cultural differences and not dichotomize sort of everyone who's pro and everyone who's con, and make simplistic assumptions. So I think we need to keep it fluid.
I'd like to ask Sarah and Rochelle a little bit more about the side effects issues. And, you know, I think Mark and Barry talked about sort of how we should think about how we should frame our expectations about these things. What are your thoughts then about sort of how to go about being transparent about these side effects, and how do we inform people about the severity? I think many people are aware that the shingles vaccine, for instance, that's out there now can have significant side effects, but it's well tolerated by people who want to avoid painful shingles. What would be our way of thinking about these vaccines relative to, say, the shingles shot, or, you know, the flu immunization that people are interested in? Could you tell us your thoughts and what your work might suggest?
Sure. Or maybe I'll just pipe in to say that I think it's important, as Mark said, to be transparent and clear in our discussions about side effects, because there's a tendency just to say vaccines are safe, it's no problem, you know, and then people don't trust that if their lived experience is different. And my mother might be the perfect example. My mother, who says, I will not get the flu vaccine because when I get the flu vaccine, I get the flu, and, you know, and so she's not getting the flu, but she's getting what are common side effects of vaccination, which are maybe a little low-grade fever, some feeling lousy. And if you don't really make it clear to people that that's expected, that's normal, that's not bad for you, but it is uncomfortable and it is unpleasant, but it's, on the other hand, better than getting the flu or COVID, as anybody who's really had the, you know, real honest God flu knows. If we don't have those conversations, then I think our credibility is eroded. And I think we should also have honest conversations about the very, very rare, more serious side effects, because I think people read about them in the newspaper, for example. They might have read about some of these vaccine trials being on pause for a moment in time because there were more serious neurologic side effects. And if we're not honest about those, I think that the public can sort of sniff that out, and the credibility of the vaccination messages is undermined. And people should know that there, as part of rollout campaigns, all side effects are tracked. Certainly serious side effects are tracked. That's part of the phase 4, what's called phase 4. That's part of the contract that the company puts in place in terms of rolling out vaccination. And even after that, there's a registry, a national, at least domestically, there's a national registry of vaccine side effects. And so all of that is really carefully tracked in order to be sure about the safety of any given vaccine.
Rochelle, I had a question for you, and that is relative to these side effects. So, you know, as a practitioner in infectious diseases, I mean, there have been vaccines in the past that did have rare but serious side effects. So in the case of one of the early rotavirus vaccines, it had to be removed from the market because of serious side effects. And then way back when, with the swine flu vaccine during the Ford administration, we saw cases of paralysis, Guillain-Barré paralysis. And so when you're thinking about the short-term side effects that may be visible in the clinical trials done so far versus these rarer but potentially more serious longer-term effects, what can you tell us about the risks and how we might weigh them in thinking about vaccination with these new vaccines?
Yeah, I think that's a great question. The true vaccinologists of this country who are sitting on these advisory boards are, will tell you that nearly all the rare severe side effects happen in the first 2 months. And so we got a lot of really important guarantees, I think, from both Pfizer and Moderna that they would not apply for their EUAs until they had 2 months worth of safety data in the backdrop to make sure. Now, it is the case that people will then say, well, we've never really had an mRNA vaccine. We don't know what's going to happen in 2 years. And we have to, I think, acknowledge that. But I think I turn to the vaccine experts who really say that those really rare ones have not manifested, and almost uniformly across vaccines, they happen early. I want to just harken back to a couple of points that are made. One, acceptability, and that is, it's interesting when you sort of say, no, I don't want it now, or yes, I do. One of the things that we've found is that when we have a vaccine shortage, more people want it. So it may very well be in the context of a shortage that more people are lining up to receive it. So that's point one. Point two, I think, is the one that Mark made, and that is hesitancy is not universal, and I think we have to treat it as local. And I just mean even in subgroups or cultural subgroups. I have spoken to colleagues in Atlanta who are talking to their patients, and not a single one wants it. Now, why is that in Atlanta but not in Hispanic communities in Boston? I think we really are going to have to treat that as local, which is why I think there's such an investment that needs to be made. And maybe the final point I will make is over these mild side effects. Yes, we see people who don't want the flu vaccine because of the mild side effects, and these are probably going to be a little more severe than we see with the flu every year. Maybe not a lot, but some. Fortunately, they happen more often with the second shot than the first, because I think we'd really have a hard time having people come back if it happened with the first. But the thing I think that's really important is, especially as we think about vaccinating healthcare workers and even other workers and essential workers, is right now I'm attesting every day when I come to work that I don't have any of those symptoms. So now what I'm doing is I'm going to vaccinate a whole healthcare workforce, but they may very well be out for some period of time because of the symptoms that they're having. And how we are going to tease apart when they can come back to the workforce, we certainly can't be vaccinating the entire intensive care unit if we think within the week 30% of them are going to have symptoms that are going to have to make them stay home.
That is a point that I don't think very many people have thought of. So thank you for telling us that. And I appreciate it. I had a question about the clinical trial design and this 2-month kind of hurdle for the safety data. I think the companies, especially now that they've got these vaccines that look highly effective, have said, well, we intend at some point relatively soon to make available the vaccine to the people in the placebo arm, the placebo group, people who didn't get the vaccine. And I wonder if people have a thought about how long would be ideal to follow people in these trials who have been in the placebo arm, and what's acceptable. Do you have any thoughts about, when should we allow, or when should people be allowed to cross over from the placebo arm into the vaccination arm?
Do you want Barry to take that?
I'll turf that to Mark.
I've thought a lot about this, and I'm actually writing something about this right now.
I did not know that. I knew you thought about it, but I didn't know you were writing something. So go for it.
So I think the first thing to say is participating in a clinical trial does not give up any right to do anything. So if someone has access to a vaccine and they're in a clinical trial, there is nothing the trial can or should do to stop them from getting that vaccine. So that's the first thing, is being in a trial does not give up your right to pursue your own health. So I think the narrower question is two things. First is, as the vaccine becomes available to very high-risk people and to healthcare workers, should those people get the vaccine? And I think in their own interests, they probably should, if they were in the placebo group before. And that perhaps the trial should facilitate that if that makes it easier for them, if they're in a group that is already ready to get the vaccine, for which there's enough supply. I think the more tricky part is with the people who are in the lower risk groups, and for whom it is not yet available on the open, and it's not a market, hopefully, but it's not available through the allocations that are going down the priority groups. And there, I would say that there's certainly no ethical obligation for the trials to give the placebo group the vaccine. And there's actually a loss to the trial in terms of its social and scientific value. A critical ethical concern in all trials is that they must maximize that value. Because we won't know, if everybody is offered the placebo, then we will no longer have data on the longer term safety and efficacy that compares placebo to vaccine in a randomized fashion. And I think doing it in other ways is much less compelling. So my strong recommendation would be that the trials continue for 2 years, as they were mostly set out to be, and that people be, of course, given the opportunity to depart from the trial if that's what they wish to do, but that those who are not in the high priority groups should be followed for safety and efficacy through the 2-year period. And that is especially important for the final measurement, where there will be a measurement of whether they have become infected during the trial, even without symptoms, using a specialized antibody test. So there's a lot of value in learning the long-term performance of these vaccines, and the trials, continuing the trials is the best way to do it while not violating people's rights.
Thanks, Mark. I had one question before we move in full force to the audience questions, and it's for Sarah, and it's relative to this timing issue, and it is, what can you tell us about the durability of the immune protection from the vaccines as far as we know it now? Is that something we need 2-year data to look at?
I think 2-year data would be good to look at that, because I think the honest truth is we don't know, especially with the mRNA vaccines. So really an mRNA vaccine hasn't been in a human population before, and so we don't have a good sense even of what those long-term immune dynamics are, as far as I can recall. And the different vectored vaccines, so the adenoviral vectored vaccines, we have a better sense of what the long-term immune dynamics look like because they've been trialed in, for example, Ebola. But how those translate into true protection against disease or protection against infection, if that's actually what's happening, I think we don't have any idea. And unfortunately, we're going to roll out this vaccine, and hopefully we're going to see a diminution of the epidemic, but it's not going away. And so, projecting forward into the future, trying to understand what that immune protection looks like in 2 or 4 years or 10 years time, I think those will be important questions as we move forward. And I don't think our answers.
Thanks very much. We have a question from Alexi Cohen at the Boston Herald, and it's related to the trial design, and it is, why have children been excluded from any of these vaccine trials, and how will this affect the efforts to either keep open or reopen schools? I believe that the Johnson & Johnson trial is going to enroll kids down to age 12. And I could be wrong about that one, but I know that, and then I think Pfizer expanded their trial also to look at some kids, but we don't know. I don't think any of the trials are looking at, that I'm aware of for the leading vaccines, have looked under age 12. Does anybody have thoughts about that, Rochelle? Maybe.
Scott, I could say
Barry.
a few words about that. I testified before the advisory committee on immunization practices a couple weeks ago with 2 chairmen of departments of pediatrics who had pointed out that they're almost, while children have been highly resistant to the severe effects of COVID, we know that kids get infected, even little kids. We know that they can transmit, perhaps not all that efficiently, but nonetheless, they are part of the cycle of COVID infections. And they were pushing hard for getting vaccines tested in kids and in pregnant women as soon as possible. And I couldn't disagree with that. On the other hand, it strikes me that until you get safety data and efficacy data on healthy adults, I can't imagine parents wanting to put their kids in line to get vaccines that they know nothing about their safety. Little kids can't give informed consent, adults can. And I think we're approaching the point with the issuance of hopefully emergency use approvals that one can start with good conscience, knowing they're safe enough to go into kids. But I would also point out there are different dosages would have to be tested in kids, so there will need to be trials in kids as well. This is not an automatic shift of the same vaccine to go into kids 2 years old. This is going to take some work and great care to take care of kids and unborn babies.
All right, thank you very much for that. Maybe if I could ask the panel, clearly, even if the vaccines work as effectively in broad use as they appear to have worked in the phase 3 trials so far, and the subsequent vaccines also do well, the supply will be limited, and it's going to take a while to get broad immunization in this country and around the world. What about the sort of meshing of public health measures plus vaccination? Maybe Mark, have you, Rochelle looks like she's got something she wants to say here. So why don't we let Rochelle start on this? I think this is the kind of question everybody can chime in on, but I'm really wondering about how we blend these things, and also what should our expectations be?
Yeah, maybe I'll just start with the easy one, and that is the day you get your vaccine is not the day you take off your mask. And I think all of us would probably agree with that. I think I'm very worried about the fact that we're going to be vaccinating our first group of people in a time where we have really rampant disease, because I think, you know, we give our vaccine a lot less work to do if we don't have so much disease out there. I do want to also emphasize that all of the data on efficacy were taken after a week after the second dose. So we're talking about the day you get a vaccine, you're not even protected until about 5 or 6 weeks later. So I think all of these are and then there's of course the issue of, we know that this is one that Mark raised, we know that it will protect you from disease. We don't know that it will protect you from infection, and therefore it could very well be that you get infected and have the possibility of shedding it. So I think that there's a lot of things we don't yet know, and I think that we will be in a much better place when our population is vaccinated, but I'm not sure that we're going to be without masks for a while.
Mark, what's your work suggest?
Yeah, I completely agree with that, and I think that just the time scale on which the vaccine is going to roll out means that we're going to be in some form of the really unpleasant and destructive interventions that we are taking for good reason right now. I mean, I'm supportive of these interventions and in fact of strengthening them, but I also admit that they are causing disruption at best to many people's, almost everyone's lives. So I think we're going to be in that unfortunate setting for quite a while because the coverage is not going to be high enough until at least sometime middle of the year, if all goes very, very well, or later in the United States. The interesting thing is that we've been working through as we've been modeling the who should get vaccine first is that if these non-pharmaceutical interventions, these social distancing and masking interventions are in place, then that actually makes the herd immunity effects, the ability of the vaccine to protect those who have not yet gotten it, much stronger, because you're only having to reduce a little bit of transmission compared to a lot of transmission. So, so there's a real synergy between the vaccine and these non-pharmaceutical interventions. And unfortunately, I think we're going to have to do both for a while.
All right, I appreciate that. Thank you. At least we've got another tool, it looks like, that will help. So let's now turn to some of the audience questions, and we've got quite a few of them. So I'll try and throw this out open to the group, and we don't have buzzers, but indicate which question you think you might be ready for. And here's the first one. It comes from Judith. She asks, in the trials, did the researchers first test for antibody to see if the person already had COVID-19? And might there be some effect of giving the vaccine on top of antibodies already in the body? I'm wondering if that might be one for Sarah.
That's a fantastic question. In the trials, they did not. So antibodies were not assessed as part of the enrollment. Is Rochelle raising her eyebrows? I don't think that.
My understanding is some of them did, and so they could correct for it on the other side, but clearly I don't know the answer definitively, and we've probably heard from different sources.
Okay, so, but actually the important part of that is actually antibodies probably do affect the efficacy of the vaccine. And so, I think there is reason to think that pre-existing immunity would then change how you read out a vaccine effect. If you were the placebo arm and had pre-existing immunity, it might look like the vaccine did not do as much over a population. So I think it's a superb question. Practically, how it's playing out in any given one, in each of these trials that's going on, is probably different.
Okay. We have a question from Charmin. Given the current surge in infections, what peak levels do you think we will reach in daily infections? And what percentage of the population in the US will already be infected before the vaccines become more readily available? Is that something, Mark, that you've thought about, or Barry?
I've been asked similar questions a lot. My answer is always the same, which is that for the next 3 or 4 weeks, we can make projections of how many hospital cases there will be and those sorts of things, because that's existing infections playing out. The future is in our hands, and one reason I don't try to project beyond a few weeks is that it's really predicting politicians, and I don't get paid enough to predict politicians. And I'm not sure anybody knows how to do it. And it's also predicting human behavior, which is complex and very different from epidemiology. So I plead ignorance about that. But I also think it's really important to remember that this is not a hurricane, right? This is not a natural disaster that we can either move out of the way or just suffer the consequences. It is to a very large degree in our control. And so another reason why I'm not a fan of long-term projections is that we really, it depends on how we behave. And if we say it's going to be such and such number, that might be motivation to try to make it less, but then you get the prediction wrong. So I think it's really important to think of this as a collective project to reduce that number rather than as something that's sort of natural force.
Maybe I'll just chime in and say, there's an old adage that says people don't change, and that's because behaviors don't change. And that's part of the reason that this is really so very challenging. All of the things in public health that require behavior change are the ones that are hardest to prevent, like smoking cessation and exercise and obesity and all of those things that really do require behavior change. I think that's been one of the biggest challenges here.
And yet we've seen differences across countries and their ability in some places to do that. I have another question, and it has to do with the virus that's out there. And are there changes in the virus? Are there different strains of the virus? Could the virus change in ways that might negate the effectiveness of the vaccines that are being developed right now?
Maybe I'll take that. So clearly you can see genetic changes in the virus as it propagates around the world. And there has been some speculation that the different viral clades have slightly different clinical manifestations. I'm not a big fan of that kind of speculation, but I think the question about whether the virus is going to change to escape immunity, either natural immunity that you got because you got infected with one strain, or vaccine immunity, is often motivated by people's understanding of flu, where there is really whole-scale genetic scrambling of the virus every year. That's part of flu's biology. Is it just like it undergoes incredible sort of genetics rearrangements. So while it is totally possible that the coronavirus can mutate away from immune protection, it's not like flu. The coronavirus biology is not like flu, and I don't think people should expect that we're going to go through this whole thing this year and we're going to have to do it again next year because there's a whole-scale new genetic reassembly of this virus.
Yeah, I think it's like the prospect of some kind of unknown side effect that we haven't detected yet. It's very unlikely, and our job is to watch for it and see, because unlikely, that's what science is supposed to do, is to make sure that things that are unlikely are actually not happening.
Barry, I have a question for you, and that is, we've been focused a lot so far on the US situation, but what about the access of countries around the world to vaccine? In particular, how will a supply of vaccine be made available to lesser developed countries?
So there's an adage in infectious diseases that a global infectious threat in any part of the world threatens every other part of the world, particularly when people can get on an airplane and within a matter of hours bring a virus from any place on Earth to any other place. There's a major equity issue here. All of the vaccines that are being made in wealthy countries, and the resources, there are 92 countries that WHO estimates can't possibly afford to buy any of the new COVID vaccines and have trouble getting the major children's vaccines out. So there are three wonderful agencies that took the lead on this, starting years ago in Norway, called an outfit called CEPI, a coalition for epidemic preparedness, that started to say we should be thinking about how to get vaccines for COVID and other potential infectious diseases in a way that would be affordable to people in developing countries. There's another outfit called the Global Alliance for Vaccines and Immunization, Gavi, which is in the business of subsidizing vaccines to make children's vaccines particularly available now in developing countries. And all of this now has hooked up with the World Health Organization to set up a program called COVAX that has organized to create a fund to be able to provide vaccines at least for a percentage of people in the healthcare, caregiving, and hospital setup in as many countries as possible. Many countries, 188 to be precise, have signed up to be part of that, either to be able to use the vaccines or offer to test the vaccines or offer to provide them. Of the countries that are participating, there is one that is not, the United States of America. And it's shameful and it's appalling. And I am greatly hopeful that on the new administration will renew our membership in the World Health Organization, renew our leadership in global health, and contribute to providing vaccines both to the people of the US, but for the people with needs in low and middle income countries around the world.
Thank you very much for that, Barry. I want to apologize now to our very active audience. Thank you all so much for your questions. We can't get to them all. We're trying, and I'm going to go with one last question, which I'm sure will be controversial. That's why I'm picking it. So we have a question that is, given the fact that we've been living with the virus for almost a year, should we just let herd immunity kick in as opposed to worrying about vaccines or some of these other measures? And I suspect that Mark in particular has been thinking about this. So I'll let him start, and then we will go to our takeaways.
Well, Rochelle and I and two colleagues have been writing about it as well as thinking about it. The idea of trying to let the virus spread in a somewhat controlled way where it only spreads to the people who won't get very sick sounds nice in theory. It's been proposed and in fact endorsed by members of the White House task force like Scott Atlas, and it has been roundly rejected by over a dozen public health groups, by the Infectious Disease Society of America, and by essentially every responsible, in my opinion, every responsible group that has thought through it. Why is that impossible? First, because we can't easily identify all those who are at high risk. Some of them are very old, and you can tell that quickly. But there are a lot of people who get very severe infections who are not old and who are not obviously ill. Over 40,000 people under the age of 65 have died of this virus. It is not simply a virus of a disease of the old. The second problem is that even if we could identify them, we have no way of shielding those people from the infection while letting it spread widely in the community. So the Swedish tried to do it, and their nursing homes were decimated. As it has spread throughout our country, our nursing homes in the areas that have gotten large surges of cases have been heavily affected. And the sort of soft version of this idea is we have to focus protection on the most vulnerable. That's uncontroversial. That's of course what we should do. But we should also be realistic that we haven't learned how to do that so effectively that we can just let it go. And so letting it go is, without a vaccine, is the wrong way to do it. Building herd immunity with a vaccine is the right way to do it. Sarah, you should add.
Well, I just wanted to add that, death is a very blunt measure. And I think we should also not forget how many side effects of COVID infection are really devastating to individuals and manifest in young, otherwise healthy individuals. Chronic fatigue, neurologic syndromes. It's not a benign infection, even if people don't die. And so again, I think sort of the simplistic view that we can let it run rampant and most people will be fine is just that, overly simplistic.
We've already run over, and I do want to make sure that we have a chance for each of our panelists to give a takeaway. And Sarah, since you were on the screen, maybe you could give us your takeaway, because I also realize you have a harder stop than some of the rest of us. So what would you like to share as a parting note from our panel today?
Well, I am struck by the challenges that we have ahead of us in thinking about rollout, and that we as a society have not done necessarily the best job in terms of getting our prevention measures in place, our response measures in place. And now we face an enormous challenge, but enormous opportunity to get this next phase right. And that we should really collectively all take part in the conversation about how we're going to roll out the COVID vaccine and who's going to get the COVID vaccine, such that we really can use vaccination as an effective tool to protect our communities.
Thank you. Rochelle, could we turn to you and ask for your thoughts?
Yeah, and I can be brief. I will say, I think history will judge how we handled this pandemic by how we treated our vulnerable populations and how we made sure that people who, however we define vulnerable, socially vulnerable, medically vulnerable, and how we do this and do this right for those populations, I think is critically important.
Thanks. Mark?
Sure. I'm not known for being an optimist. My wife jokes that I have a resting grim face, but I think the news about the vaccines is really good news. It is the best news we could have hoped for, and presages even good news about future vaccine candidates, I think. So I think we do have an incredible opportunity, as Sarah said, and I think what we need to do, regardless of the vaccine, is form a greater sense of resolve as a community, as a country, and as smaller communities, that this is a hard problem that we have to defeat with a whole bunch of different measures, and that the vaccine is an incredible tool, but it's only one, and it's not going to solve the problem immediately. So we have to keep our resolve up to reduce transmission with all the means at our disposal. So I'll close by saying, try to keep your Thanksgiving very local and very small.
Thank you. Thank you very much, Mark. And Barry, what can you tell us? How can you synthesize our wonderful 1 hour and a little bit more panel into a minute or so?
There's a photograph of a young African child that has touched me greatly, holding a sign that says, "Thank you, science." I think what we've heard today is that with the combination of efforts of investment in basic science, in the application of science to developing effective products, from the commitment of companies to make major risks to produce these vaccines, the science has come through for us. The real challenge now is to get public acceptance of the vaccines that will be forthcoming. And here I recur to the March of Dimes, which was a completely private foundation for the public good and eliminating poliomyelitis, and got almost all the children in the US vaccinated. It was a foundation, it was not the government. And I am looking forward at halftime to football games on Sunday to seeing advertisements not just for erectile dysfunction and plaque psoriasis, but on the importance and value of COVID vaccines to get into everybody possible to end this terrible epidemic.
Well, thank you very much, Barry, and thank you to the rest of our panelists. I think we just heard an argument in favor of a certain kind of DTC advertising, which I did not expect to emerge from our panel today. But thank you very much. So that concludes our event. I'd like to again thank our panel. This Q&A has been jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and NPR. Look to the Forum website for more information on this and the future events. And you can always look to NPR both on the air and on the web for more information about coronavirus and COVID-19. Thanks very much, everyone.